welcome you all to the virtual academic program of Oncology Club. So in the era of this social distancing, we have been trying to do a social connecting. And today our session is how should I treat my patients following evidence-based medicine. Sorry for the time, it was supposed to be 7 to 9, but now it is again 3 to 4:30. Our faculty is Dr. Sadia Sharmin, who is the Associate Professor of Oncology Department in Bangabandhu Sheikh Mujib University. Just to introduce her, I can tell that I had the opportunity to see her in 2011-12, and at that time, she was the most brilliant student that I have ever seen. And she has done justice to her, and now she is a very promising oncologist and doing a great job in university, and she will be enlightening us with metastatic breast cancer management. And our overseas faculties are Dr. Mohammad Zakirullah, S.K. Farid, and hopefully John will join us. So our patron and president, Professor Heiser, who always blesses us with his presence, will be joining us a bit later because he was occupied in a health checkup issue, so he is a bit late, but he asked me to start the session. So our program will be from 3 to 4:30, 90 minutes, and this is the distribution as usual. And we will be having the faculties like up to assistant professor, and we will expect that the junior will be asking the question, and the presenter will answer the question, and if required, faculties will supplement. So this is all about today, and now I would like to request Sadia to share the screen and start her presentation. Sadia.
Thank you, Kamal Bhai. Am I audible? The sound is okay? Bhaiya?
Okay. Yes. Sound okay. Screen share karo.
Yes, you are
Screen share karo.
Thank you, Kamal Bhai, for inviting me to present the management of metastatic breast cancer in this forum. First of all, I want to thank Oncology Club for arranging such a beautiful webinar, and it is very interactive. Now, I am going to present my topic, and it is on metastatic breast cancer. Metastatic breast cancer is defined by tumor spread beyond the breast, chest wall, and ipsilateral regional lymph nodes. Most common sites are bone, lung, liver, lymph nodes, chest wall, and brain. Most women with metastatic breast cancer will have been initially diagnosed with early stage breast cancer treated with curative intent and then experience metastatic recurrence. And some percentage of women may present with metastatic disease at presentation. In United States, it's 10% of patients, but in proportion is far higher in areas where screening programs are not available, like Bangladesh. Now, what are the risks of metastasis? It depends on biology of tumor, the stage at the time of the original diagnosis, the treatments for the original cancer. These are the types, in broad headline. If we subdivide the breast cancer patients, it's hormone receptor positive, HER2 positive, and triple negative. What is the goal to treat the metastatic breast cancer? It is not curative, but some goals are there. That is the longest survival, fewest possible side effects from the cancer and its treatments, and best and longest quality of life possible. When we suspect a case like metastasis or a patient come to us with metastatic breast cancer, first of all, we do some workups. There are some biochemical tests, radiological imagings, and brain or spine MRI, or if CNS symptoms or like such symptoms like back pain or some other symptoms. FDG PET scan is optional, and I should emphasize on the biopsy of first recurrence of disease so that we can determine the ERPR and HER2 status of the metastatic disease. And FDA approved some biomarkers for these patients. For all patients, we should do BRCA1/2 mutation. In hormone receptor positive, L1 expression is important regarding treatment, and for all patients we can do NTRK infusion or MSI. This is the chart where we can then we should see, or we should see that what types of treatment patient got before. If initial treatment is lumpectomy plus radiotherapy, then we should go for total mastectomy or like axillary management accordingly. If initial treatment is mastectomy or level 1 to axillary dissection, then we can do surgical resection if possible. And if initial treatment is mastectomy without RT radiotherapy, then surgical resection if possible, radiotherapy. And if there is regional and locoregional recurrence, that is axillary recurrence or supraclavicular or internal mammary node recurrence, we can treat accordingly. If patient present with only bone only disease, then we can add denosumab, zoledronic acid, and pemitonate. And bone disease, if not present, then we can go according the treatment. We can go according to the receptors and the other options of the treatments. Regarding denosumab and zoledronic acid, I should emphasize that we can before going to that type of treatment, we should see the survival of the patient, that is the expected survival of the patient, what is the renal function of the patient, and before initiation of the therapy, we should uh, check the dental status of the patient. Now, hormone receptor positive metastatic breast cancer. If the patient present with metastasis and the biopsy shows that the hormone receptor positive, then we can go the other test and see whether there is visceral crisis is present or not. If not, then the first option is endocrine therapy. And for premenopausal women, the endocrine therapy will be ovarian ablation or suppression or systemic therapy. Endocrine therapy is a key intervention for women with hormone receptor metastatic breast cancer. Single agent therapy is a standard approach. On average, first line treatment is associated with 8 to 12 months of tumor control, and second line treatment with 4 to 6 months. Endocrine therapy can cause regression of soft tissue, bone, and visceral metastasis. Now, for the premenopausal women, the newly diagnosed premenopausal women with metastatic breast cancer and hormone receptor positive, the preferred option is ovarian suppression ablation plus tamoxifen. It can improve survival compared with either tamoxifen or ovarian suppression. And if metastasis occur despite of previous tamoxifen in the adjuvant setting, then aromatase inhibitor is the option with ovarian ablation. These are the incision guidelines where we can suggest second line or third line hormones if patient progress in spite of hormone therapy. And if patient presents with visceral crisis or progression with unacceptable toxicities, then sometimes we should switch over to the systemic therapy. These are the options for hormone endocrine therapy for metastatic breast cancer. And for postmenopausal women, I already told the premenopausal women, and these are the options for the premenopausal women. And for the postmenopausal women, the optimal sequencing of endocrine therapy for postmenopausal women is not so clear. Who receive prior aromatase inhibitor in adjuvant setting? The tamoxifen, fulvestrant, progestins, possibly different aromatase inhibitor are all reasonable options among such patients. These are the agents we can suggest to postmenopausal women. Now, what is the role of fulvestrant? Whether it is given with aromatase inhibitor, whether it is given alone. There is an important study that is SOWG226, which shows that there is two arm, that is anastrozole 1 milligram in single in one arm, and anastrozole and fulvestrant in another arm. Aromatase inhibitor and fulvestrant can be used combinedly for de novo or progressive estrogen receptor metastatic breast cancer. This trial suggests combining these two agents shows improved progression-free survival and overall survival in patients who receive prior tamoxifen and aromatase inhibitor. Don't show the combination of aromatase inhibitor and fulvestrant superior to monotherapy approach. Thus, the combination of an aromatase inhibitor with fulvestrant is appropriate primarily among women with endocrine naive patients. This is the FACT trial, which also done to compare the anastrozole and fulvestrant. And what is the summary? It is the summary that the two studies, that is the SOWZ 226 and FACT trial, the combination of both the trial shows the combination, compare the combination of fulvestrant and aromatase inhibitor with aromatase inhibitor alone. And the SOWG trial showed improvement in progression-free survival, but FACT do not. These are these slides showing the development of the endocrine therapy in breast cancer patients. Now, what about the endocrine resistance? This is the model of how describe how endocrine resistance may develop in breast cancer patients. Most patients with hormone receptor positive metastatic breast cancer eventually progress despite of first line endocrine therapy or subsequent lines of endocrine therapy. Resistance may develop and it does not indicate loss of hormone receptor expression by the tumor cells. Oral everolimus 2 trial approved mammalian target of rapamycin inhibitor, that is the mTOR inhibitor, everolimus in the advanced setting of patients. This is an important trial in everolimus in postmenopausal hormone receptor positive advanced breast cancer. This is the Bolero trial, which compared the everolimus and exemestane versus placebo and exemestane, and it shows improvement of in cancer control with combination. So FDA approved everolimus for breast cancer in July 2012. What about the cyclin regulatory? This is the another options for hormone resistant metastatic breast cancer. We can use CDK4/6 inhibitor for these type of patients. These slides showing how cyclin D inhibitors works in metastatic breast cancer. The Paloma trial showed the palbociclib plus letrozole versus letrozole alone, and it shows significant median progression-free survival with the combination arm. The Paloma True trial also in between palbociclib and letrozole versus letrozole placebo, and it also showed significant improvement in median progression-free survival. Now, Mona Lisa trial, it comparing the ribociclib and letrozole versus letrozole alone in hormone receptor positive metastatic or advanced breast cancer, and it is also showed some significant result in progression-free survival advantage. So these are the CDK4/6 inhibitor that already received the FDA approval. That is the palbociclib in 2016. In 2017, the ribociclib, and 2018. That is the abemaciclib. These all can be used in postmenopausal hormone receptor positive HER2 negative metastatic or advanced breast cancer. Now about PI3 kinase inhibitor, that is the albociclib. It is the PI3 kinase inhibitor. On May 2019, FDA approved albociclib in combination with fulvestrant in postmenopausal women. This study showing the results between combination of alpelisib plus fulvestrant in men and postmenopausal women with hormone receptor positive breast cancer. And this trial also showed some significant improvement in progression-free survival, but no overall survival benefit got in this trial. Now, what about the chemotherapy? Chemotherapy or cytotoxic chemotherapy remains a mainstay of treatment for metastatic breast cancer. Chemotherapy is used in patients with hormone refractory or hormone insensitive tumors. Tumor response to chemotherapy surrogate for longer cancer control and survival. First line chemotherapy associated with higher response rate, obviously, and longer tumor control than second line or so forth. Debate is there whether single agent or combination treatment with multiple agent is the best strategy. The decision should be individualized. Grossly, patients with extensive visceral disease or pending visceral crisis preferentially require initiation of combination chemotherapy if patient condition supports. These are the regimens we can suggest to our patients for metastatic breast cancer treatment. I am not going in details, and these slides also showing the different regimen. And these are the agents we usually or commonly used for the treatment of metastatic breast cancer patients. Now there is a newer options for regional chemotherapy. Already 6 non-randomized trial already done to study the role of regional chemotherapy, mainly by chemoembolization and uh, chemotherapy perfusion. Now the targeted therapy. Sorry for the interruption. Now for the targeted therapy, what about the HER2 positive breast cancer disease? When trastuzumab added to HER2 positive breast cancer, it improves response rate, time to progression, and overall survival. Trastuzumab is an important agent or monoclonal antibody for the treatment of HER2 positive breast cancer. This slide showing the NCCN guideline 2020 regarding HER2 positive breast cancer management for the advanced disease or metastatic disease. And there are several agents already have been come for the HER2 positive breast cancer disease. Now, what is the mainest options for HER2 positive metastatic breast cancer patients? That is the taxane, trastuzumab, pertuzumab, TDM1. If progress, then capecitabine, lapatinib, or trastuzumab plus other agents. Pertuzumab is a different HER2 antibody than trastuzumab, which binds to both HER2 and HER3 proteins. Clinically, the activity of pertuzumab seems to be dependent on co-administration of trastuzumab. This is an important trial, the Cleopatra trial, which comparing the results of the treatment between pertuzumab, trastuzumab, and docetaxel versus trastuzumab and docetaxel, and it showed improvement in both progression-free survival and overall survival with the addition of pertuzumab along with docetaxel plus trastuzumab as first-line treatment with HER2 positive breast cancer. The major benefits of these therapies have only been proven in combination with chemotherapy. A variety of chemotherapy agents have shown clinical activity and safety when paired with trastuzumab, including taxane, vinorelbine, platinum analogs. And what for the patients who develop resistance to HER2 positive breast cancer? There are several options. Some newer agents come: adotrastuzumab emtansine, famtrastuzumab. These are the very new options for the resistant patients, and these are the novel agents linked to chemically linked to potent chemotherapy moiety and can be used in trastuzumab refractory cases. In a randomized trial of trastuzumab resistant breast cancer, TDM1 was found to be superior to the combination of lapatinib capecitabine with respect to progression-free survival and overall survival and tolerability. This is the Emilia study done to show the response rate of TDM1 versus capecitabine and lapatinib in HER2 positive resistant cases. And these studies show that TDM1 far better tolerated than capecitabine and lapatinib. Now, what should be the optimal sequencing of therapies? The current treatment algorithm for metastatic HER2 positive disease in first-line treatment is taxane, trastuzumab, pertuzumab, based on unprecedented result from the Cleopatra trial. For second-line treatment, the antibody drug conjugates adotrastuzumab emtansine, that is the TDM1, is recommended based on result of Emilia trial. Now, it is the ESCO issued treatment algorithm for HER2 positive metastatic breast cancer. Now, what is the role of tyrosine kinase inhibitor? The lapatinib is an important drug as a tyrosine kinase inhibitor, and it has been studied as second anti-HER2 therapy for patient progressing after chemotherapy and trastuzumab. It is the dual kinase inhibitor targeting both HER2 and EGFR tyrosine kinase signaling pathway. Capecitabine alone versus capecitabine plus lapatinib showed longer period of tumor control and improvement in response rate, but no survival benefit. Lapatinib can be used in different settings like lapatinib combined with chemotherapy, lapatinib combined with hormone therapy, lapatinib combined with trastuzumab, and lapatinib with brain metastasis. The another tyrosine kinase inhibitors for breast cancer patient is tucatinib, and very recent in 2020, the FDA approved neratinib in combination with chemotherapy drug like capecitabine is used to treat HER2 positive metastatic breast cancer. There are some new recommendations. Now about PARP inhibitor for the hereditary breast cancer, it is the emerging options for BRCA1/2 positive breast cancers, and it is available in Bangladesh already. And the most important PARP inhibitors are olaparib and talazoparib. It can be used in BRCA1/2 positive hereditary breast cancer patients. Now immunotherapy, pembrolizumab, atezolizumab are the important immunotherapeutic agents that can be used in metastatic breast cancer, and it is described very in details in the previous presentation. So I am not going in details for the immunotherapy. These are the NCCN guidelines for 2020 for the additional targeted therapies in metastatic breast cancer, and very new agents like FDA approved in this year. This is the satizumab govitecan. Now, what about the local or regional treatment? Radiotherapy or toileting surgery or palliative surgery is an option for metastatic breast cancer patient. When what is the role of local treatment, or in which situation we should suggest the local treatment? That is the when the breast tumor is causing an open wound, to treat a small number of platelets in that area to help prevent wound fractures. When an area of cancer spread is pressing on the spinal cords, to treat the blood vessel blockage in the liver or to provide relief of pain or other symptoms. When there is no hope, then we should, or patient do not responding to any therapy, then palliative care is the last option, and there is always a transition to palliative care with metastatic breast cancer and the supportive treatments also. These are the recent publication of 2020 that is already been published in Metastatic Breast Cancer Journal in January, in July, and in some. Now I want to conclude my session, that is the treatment of metastatic breast cancer remain challenging. New biologic and targeted agents are adding to the wide choices of standard chemotherapies already available. It is also becoming increasingly clear that metastatic breast cancer is a heterogeneous disease and there is no single optimal strategy for all patients. Many patients have an indolent course of progression, and those who with limited stage 4 disease are being considered for surgery and multimodality therapy with the goal of further improving their survival. Ultimately, physicians should be guided to rational and flexible treatment regimens for their patients by current based clinical guidelines and ongoing research. Thank you. Thank you for patient sharing.
Thank you, Sadia. You have done an impossible job. Within such short time, you have covered metastatic breast cancer. You deserve a congratulation for that.
Thank
so
you,
now
ma'am.
let's see how our colleague respond. So the floor is open for question and answer. May I request our junior colleagues to ask question to Sadia.
Madam, Assalamu alaikum.
Walaikum assalam.
Thank you for your nice presentation. Madam, what is the recommended dose of radiotherapy for ovarian ablation?
Ovarian ablation. Usually, for ovarian ablation, recently the surgical options and the gonadotropin, the GNH, GnRH analogs is mostly used for ovarian ablation. Nowadays, radiotherapy is not so much practicing that for the ovarian ablation. I think so. I should suggest for surgical or GnRH analog for ovarian supply.
Can I add something with this? Because
Yes,
I
yes.
have some experience of radiation ablation of ovary. So usually in the metastatic cases in Cancer Institute, most of these underprivileged patients and they are not afford the gonadotropin releasing hormone antagonist. So I usually do the radiation ablation of the patient. I use 16 gray in 4 fraction. Okay, 16 gray in 4 fraction. Uh, Usually it should be done with an ultrasonography guidance. Just before doing the planning, you have to do the ultrasonography and the radiologist will point the ovaries according to the, because ovaries are very mobile. So he or she will just mark the position and I will then plan with covering the hole, and 16 gray in 4 fraction is the usual dose in consecutive 4 days.
Thank you, madam.
So I want to add that radiation is an option, but it is GHNH analog are more recommended because of its, even we use whatever it is, ovarian suppression, we need to remember if it is not oophorectomy, then we need to check the hormone level before claiming that we have done adequate ovarian ablation, especially by radiation. Because in GHNS analog, it is a continuous process, at least for 5 years. Sometimes it goes beyond 5 years. So that is a continuous process. That's why this is a bit debatable. But yes, as Lima said, it is less expensive and it is effective.
And when I have to do the ablation, not the suppression, I have totally ablate.
Here it is permanent.
I can use permanent.
It is not it is a irreversible, but it is a option and it can be done. There are many fractionation. What she said, that is also fraction. Yes, Riyad.
Thank you, Assalamu alaikum, madam. Thank you for your nice presentation. My question is, in case of hormone receptor positive and HER2 positive metastatic breast cancer, should we or can we start hormone therapy along with HER2 targeted therapy first, or should we start chemotherapy with HER2 targeted therapy?
It is hormone receptor positive and HER2 positive breast cancer.
Yes.
And yes, we should first of all, we should do all the investigation, that is there is any visceral crisis or what are the sites of metastasis, we should first determine. Then we should do, if there is a low risk group, that is bone only metastasis, then my first choice will be the endocrine.
Endocrine alone or endocrine therapy with HER2 targeted therapy?
It can be combined. It can be combined, Riyad. You have Sadia.
Sorry, I was muted. Yes, if the patient is not received previously the HER2 antibody adjuvant setting, then we can combine the hormone therapy with the HER2 against the anti-HER2 antibodies. But we should determine the stage, like what is the risk group of the patient, whether he is in low risk or in high risk first.
The chat box, I see Dr. Savana Kumar Chinnakati. He has a question. Will you please unmute and ask the question? I think he's from...
good afternoon to everyone. So I just want to ask you, what is the role of liquid biopsy in breast cancer? Is there a role as on today? Okay, I think other questions I'll just let you know. Can you answer this?
Yeah, so...
Yes, liquid biopsies is important. In metastatic setting, we should do some biomarkers for taking the further treatment decisions. We should do liquid biopsy for that is the PD-L1 status or PIK3CA mutations we can see with the liquid biopsy. And also I should suggest some other biomarkers, though all the drugs is not available in Bangladesh right now, but some are available, so that we should suggest the patients to do the liquid biopsy.
No, is it available in Bangladesh now?
Yes, it is available in Bangladesh, the liquid biopsy.
No, do you do PCR or NGS? What do you do on that?
Now we mostly do PCR. I think so.
PCR, can we do like You told liquid biopsy. I don't know whether they do PCR or liquid biopsy. Okay,
They
like,
mostly in the molecular lab centers in Bangladesh, they mostly do the PCR based.
no, I was searching yesterday in the net. So there is
Hmm.
no NGS available in Bangladesh. I don't know about it.
No, there is
So
no
just want to
NGS
know.
still available.
No
You are
NGS.
correct. But there are some private lab are doing some PCR, but not a whole range of NGS is there. Number one. Number two, liquid biopsy, even in university they are doing, not for all sites, especially they are doing for gynecological malignancies. But as you mentioned, and for, still now, NGS is not available in our country. So welcome, John.
Yeah, one more thing. See, I think you are talking about GNRH analogs. I think
Yes.
GNRH analogs are not available in Bangladesh. I was just searching about the because I had 2-3 patients, so GNRH was not available. So I just want
No,
to.
It is available.
Which one is available? Which GNRH is available? I just want to know.
AstraZeneca's product MGH marketing this GNRH.
Zoladex is
Zoladex is available in Bangladesh.
Okay.
Liprin is also available. Zoladex, Liprin, both are available.
Liprin, both are available.
Liprolite.
No, I was searching about that some Incepta, some app is there. No, in that I was searching, it was not there. GNRH analog.
No, you need to contact with local agent of AstraZeneca.
Okay.
They are having the Zoladex and the UniHealth, Unimed, that UniHealth Pharma. They are the agent of Liprin report, and Radiant is bringing Degarelix. So all the more or less all the combinations now we are having.
No, is it available in all the pharmacy or like how is that? We have to order every time?
No.
You need to go to the supplier. It is not in all pharmacy. It is not available.
Because I was searching in that app, it was not there. So I thought it is not available.
It is there. So you can talk to your pharmaceutical colleagues. They can help you. So any more questions? Thank you.
Okay.
Thank you for
No. Thank you.
So any more question from the juniors?
Madam, assalamu alaikum.
Walaikum salam.
Madam,
louder.
In case of immunotherapy, which one is more preferred in metastatic setting, either pembrolizumab or atezolizumab?
The pembrolizumab is already established, and the newer agent is atezolizumab. But if you see the response, it is not 100%. You see, if PD-L1 is positive in metastatic breast cancer patients, then you can suggest the immune therapy. And for immune therapy, it is the cost burden you should consider because it is very expensive, but there is no overall survival benefit, but the disease progression will be delayed. That is, progression-free survival is more, but the cure or the overall survival is not so much promising. So you should consider all the factors, and then you can suggest the immune therapy. And pembrolizumab is the first agent, and in this year the atezolizumab has come, but these are not available in Bangladesh. The patient should bought from abroad, I think so.
No, atezolizumab is also available in Roche. They have bought
Roche. Okay.
Yeah, and
one of my patients have bought from Singapore, I think so.
But they don't have the base dose, that is 840. Now they have the 1250, only the lung dose, but they can arrange for the base. And one good news is that the platform for the testing the PD-L1, this is Ventana SP142. It will be also available in Armed Forces Medical College very soon, which is I think it's a great news for us because we don't have to depend on our neighbors for that. We have that platform.
Because without PD-L1, we can
And for metastatic setting, the trial suggests that atezolizumab is now the current recommendation, and for neoadjuvant is the pembrolizumab. So for metastatic setting is
in this year, the atezolizumab was FDA approved for the metastatic breast cancer very recently. I think in February, but I did not cover the whole immune therapy in this my lecture because it is already very vastly discussed. Yes.
Yeah, but I think the most important breakthrough of immunotherapy in breast cancer is in triple negative, because that is not in the normal thing. because in normal we have so many options. But the inpatient 130 was a big breakthrough for the triple negative because we are more or less helpless when it is a metastatic triple negative.
Metastatic.
So we don't have much target. So this is a real good breakthrough is there. Yes, as Lima said, metastatic is atezolizumab, but in neoadjuvant it is pembrolizumab.
Okay.
So there is a question again from Sabar. Dr. Chinnikar.
Shavana. Yes.
Yeah, I just want to ask you this PIK3 mutation. Will you do it at upfront diagnosis or you do it at recurrence?
Usually, mainly we want to do it in recurrence setting.
So you want to do it on biopsy, like original biopsy or liquid biopsy you want to use it? Which one you want to use?
Both can be done, that is tissue biopsy or by liquid biopsy, but in our country, the liquid biopsy mainly done or preferable. There is tissue, then tissue biopsy.
Shahida wants to supplement.
Yeah. So yeah, and not supplement. I have a question also. So the PIK3 mutation, should we just advise it in a first metastatic setup, that is upfront, or in the first metastatic setup, we offer the combination of CDK4 and AI, and then the patient progress that time, or in the very first. This question is to Dr. Kamal mainly. So should we?
Okay. So, there was a big debate last week, and actually, we have now it is a targetable mutation, and there is a big noise about it. We can do it on the first metastatic site also, or we can wait when we are exhausted, because there are many issues. Number one, it is not the magic drug. It is not going to give a huge benefit, and there is toxicity of the drug and the cost toxicity. So financial toxicity and drug toxicity. It is a huge. So if it is not a unique scenario that it is PIK13 is the only option, otherwise I will wait till I exhaust my most of the option, then I will go for this.
But in
the very first, you will not do it after just failure of first line treatment in the metastatic.
But in NCCN, they suggest in first recurrence.
Yeah.
When the biopsy is done for first recurrence cases, then they suggest all the biomarkers for the patients and PIK3 for the
is recommended for second line treatment, not the
for second line treatment. But
usually
biopsy is done in the first recurrence. All the time the patient recur or that patient cannot responding to the treatment, we usually do not do biopsies.
You need to do the biopsy. You keep the tissue, do the
tissue. Yes.
Why I'm telling you that PIK13 they have recommended early, not only for the targeted drug. PIK13 give you some prognostic information. PIK13 positive is not well responding to chemotherapy. There are some few issues, but again we need to justify what we are going to do. How much is the benefit of doing a PIK13, and what is the cost? And end of the day, if it is not an insured product, so if we are not giving Alpacip, and even we give, we heard from our colleague from the neighboring country, even they are getting on compassionate program, it is so toxic. Many of them were not very happy with it. So to me, there is a drug toxicity, there is financial toxicity. So we need to keep it, and we use the old block. We don't need to do a new tissue biopsy. The first metastatic site block can be used for subsequent PIK13 mutation test. So I think there is a question from Debraj.
Assalamu alaikum, sir. Thank you, madam, for your nice presentation.
Thank you.
I had a question about PARP1 inhibitors, that is olaparib or something. Do we prefer it over the CDK4/6 inhibitors? And when should we do the BRCA1/2 mutations for all patients or not?
In NCCN 2020, you already you have seen that in all patients we should suggest or we should advise for BRCA1/2 mutation because it has the both prognostic and therapeutic role. If BRCA1/2 mutation is positive, like the hereditary breast cancer, then you can suggest for PARP inhibitor, but not in the first line setting. I think so. Where you should suggest the other drugs, then that is if you suggest the platinum based chemotherapy and all other things, then in second line you can suggest the PARP inhibitor because it is very expensive drug in our context. And in all patient you can suggest or in the BRCA1/2 mutation, and then you can advise them for PARP inhibitor or olaparib.
Okay, Sadia, I want to add here that yes, we should do BRCA mutation, not only for, again, not for the targeted mutation. Again, we need to know that if it is a positive, then we need to think about the high risk group, families, and we can do a genetic counseling. That is a more important thing because PARP inhibitor in breast cancer is not yet a very, very promising like ovary. It is an option. We can keep it because in breast now still we have so many options. But at one stage, yes, if it is a BRCA positive, we have the scope for PARP inhibitor. Even if it is a BRCA positive, then in triple negative there is a study. They have shown that you can use platinum.
Olympiad studies.
A very good response. So again, this type of mutation, we should not think about only one drug. We need to think about this mutation gives us many information, like the risk factor, like the prognosis, like say genetic counseling. So we don't think PARP inhibitor is olaparib. No, we need to think in a broader way. And there is a question from Aisha. Dr. Aisha, I think she is from Pakistan, if I'm not wrong. Aisha,
I have the same question.
You're not participating. Your question, please.
Assalamualaikum, Dr. Sharmin, very enlightening presentation within a very short period of time. Thank you very much. Yeah, I want to have a surgeon's point of view as well because this is the most controversial topic whenever we discuss the role of surgery in the metastasis. So I want to know, okay, what are the practices there in Bangladesh or in the UK for the metastatic disease and the surgery? Thank you.
Okay. From my side, I want to add that if the de novo metastatic breast cancer, that is the primary is present and patient is present with metastasis, then there is a role, but there is a controversies. First of all, if this type of patients come to you or come to us, we should suggest the systemic therapy first, and surgery should be done for a special setting of patients. Like we should do the other tests and other parameters should be considered, and if patient very satisfactory or very successfully respond to our systemic treatment, then surgery is an option for those type of patients. And if you want to know about the palliative surgery, then there is a broad role in palliative surgery in these metastatic breast cancer patients. But I want to take comments from our overseas panelists so that they can add regarding this issue.
So, who will volunteer, Farid or Zakir Bhai?
This is my question also. I was preparing this question. That so should I add my question with this also to our two overseas doctors?
Overseas panelists, yes.
Okay. So Dr. Zakirullah and Dr. Farid, my question was like Aisha. So if a lady like 48 years old postmenopausal lady presented with a T2N1 lesion, ERPA positive, HER2 negative, and she is symptomatic back pain she has. So after bone scan, there is a increased uptake in the lumbar 5, and it is proved as metastatic. And other metastatic investigation is normal. So it's an oligomass operable breast with a single metastasis in the bone. So should we go for a curative intent or a palliative intent for this patient? In general or in case-to-case basis?
Let's start. Yeah. First of all, Sadia, it's a fantastic presentation.
Congratulations.
And also the question came from Aisha, I think, from Pakistan, what I understand. Start that question first. Of course, if somebody has got metastatic cancer, as Sadia said, they will go for chemotherapy first. It depends on what kind of metastasis, but of course, I'm talking about, it's a lymph node metastasis with the oligometric, which will come as well. Then we should have a intent of curative intent. It's not only single bone metastasis. Sometimes we can see some oligometric metastasis of the supraclavicular lymph nodes as well, or in the neck. Then we should think about curative intent. So get chemotherapy or immunotherapy, whatever is necessary. restage the patient and see where the status is, either CT PET scan or CT or bone scan, whatever it is. And if we find this is very solely unifocal, that is the oligometastatic patients, then you should do the surgery for your breast. After that, the area, if it is a bone, single bone metastasis, of course, by oncologists, they can actually do that particular area of different types of ablation therapy, ablation treatment, whatever available now. John will tell you exactly what are the things they can do. For unilateral lymph node metastasis, for example, supraclavicular, what we are doing now, after axillary clearance, at the same time, we can do neck dissection as well and take all the lymph nodes out from that area if this is the primary intent of curative intent. So this is one way. Second way is cutaneous metastasis. Sometimes you can see only around, not only the breast cancer is there, there's some cutaneous metastasis over the skin of the breast as well. Of course, it's stage 4, you can tell. But surgery-wise, we can remove all of this cutaneous metastasis and we can do reverse abdominoplasty type of technique to close the wound. So wound closure should not be a problem. So our surgically main idea, 1, 2, 3, I'm telling you, yes, if it is curative intent, you do absolutely maximum surgery possible. Yes, if it is oligometric metastasis, yes, to surgery or other treatment options as well to cure in the intent of cure after chemotherapy. And last thing is, if some sort of metastasis, you can see the cutaneous metastasis not at the site of the cancer, but every other organs are completely free, we can do electrochemotherapy nowadays. It's not a completely curative intent, but electrochemotherapy in localized area of cutaneous metastasis, can use that with bleomycin and other injections, and it works. Patient actually can survive for a longer time. So these are the things we normally do in UK. And of course, Farid can add as well.
Would you like
So can I interrupt and ask that from your explanation, sir, I got that surgery with the curative intention should be done for the oligometastatic disease, but it should not be done upfront. It should be first be treated by some systematic therapy and then should be done. Is it so?
That's what I'm saying. First of all, our intention would be to have some chemotherapy or whatever neoadjuvant or what treatment we have got, and then we'll measure the size of the cancer, usually stage. If it is a breast area, we always put some marker clip so that sometimes it can completely vanish. If it is not breast, in liver, sometimes you can actually identify that area. Of course, liver metastasis normally doesn't completely disappear. If it's a unifocal liver metastasis, even 2, 3 small metastases can be resected out later on, or you can do an ablation as well. So yes, your answer is, you're absolutely right. Systemic therapy followed by local therapy.
So I wanted to know some evidence in favor of this also, because I was looking for the trials, and I have seen 2 recent trials. One is from Turkish trials, and I think they just presented in 2020 ESPO, and another is TMH trial. So both are quite different, their outcome. So in TMH trial, that was they have a significant progression-free survival in the local site, but there's a detrimental progression-free survival in the distant site when they use the local therapy, like surgery. And the Turkish study, they also showed that there's no survival benefit, overall survival benefit or a quality of life benefit when they use the local regional treatment for a metastatic breast cancer. But there are other trials also, I think that are all the last decade trials. Some Khan is quite a large number of patients, about 16,000. But they showed that there is a 9 to 10% of median survival benefit when used local therapy. So I'm a bit perplexing situation. What should I pick? There are conflicting results of different studies.
Exactly. This is a very new
during competition, I will bring a few references. I knew this controversy will come. Let us have the discussion. But for your information, because the Turkish trial, that is a serious weakness. That's why they got a conflicting result, because the randomization was not proper. And initially it was not a positive trial, negative trial, but later it became a
5 years it was positive, but after 8 years it's not that positive.
Yeah, no, not 8 years. It is. We will discuss. Let us go to some other.
Yes, no, yes, you're right. I mean,
So, any comment for it?
Yeah, for it. You can comment now.
Zakir bhai.
Oh, no. What I'm trying to say, the concept is very new as well. When in the past we never actually thought about oligometric cancers can be curative. That concept is as well. And KMH tried what you're saying. Of course, some possibility is there. As Kamal said, a Turkish trial was not correctly done. It's a flawed trial. So as we go further, I mean, we started doing most of these oligometric cancer patients surgically, curative intent. And I mean, from my own experience, I can say that patients, the number of patients we have done, not very big amount, but still it's about around 5 to 10 patients. We are seeing some survival benefit, and definitely recurrence-free survival is definitely higher if you just left it behind. However, we haven't gone to any trial personally, but I think in future we'll see much better outcome because the immunotherapies and chemotherapies and other drugs are so effective nowadays. So the treatment, half of this treatment is actually done by the oncologist, and the last bit, or 30%, 40%, is just mopped out by the surgeons. I'm sure it will be much better in future.
And I think patient selection is very important for local treatment. Patient selection, not generally on.
It's a definite oligometric metastasis, not multiple sites, and you actually confuse. It's very important for it.
Aisha, are you happy with the answer?
I was just going to say,
yes, sir. Yes, sir. Because whenever such type of the patients we encounter, we always have a very important discussion in the tumor boards. So one thing is very sure that we always discuss such type of cases in our tumor boards. And yes, we already have very divided opinion, and then somehow we end up in some decisions. But yes, that's true that whenever we go for the surgery, then surgeon whatever has said that we have the similar practices usually.
Okay, so Farid, would you like to add something or nothing new?
Thank you. Nothing additional into you. Zakir Bhai has very brilliantly explained everything, covered kind of everything.
There was a question from you, Kallur. I think we are going to finish. We are going to go to the next section. Kallur is the last person to take that. We are going to take the last question from Kallur.
Okay, thank you very much, Dr. Sadia, for a nice presentation. As a surgeon, I want to know the cost because we have had many options for metastatic breast cancer, but I want to know about the cost in Bangladesh of the drugs. And another question regarding another issue is regarding the oligomets. So for oligomets, I have read a few papers. I cannot mention now because I didn't memorize those names or something. But regarding the oligomets, what we can do is give systemic therapy first, see whether the disease is stable or not. If the disease is stable, then go for surgery or some local treatment or local regional treatment. If the disease is not stable, if the disease is progressing, then there is no issue of going for surgery or local regional treatment. But if the disease is stable for a certain period of time, then possibly we can go for the local regional treatment. Thank you.
Last one, can you?
Pathology. It is neither metastasis nor primary. They say it is an in-between entity. So we need to treat it a bit separate way. And always, if there is a good response, we try to treat in a curative intent. So oligomets is a totally different world. And the world is now chasing oligomets. And there are many controversies again. How many lesion is oligomets? When you go for curative, what is a good response? So I think we don't open the jukebox here. If I open it, this 1 hour will go for oligomets. So
one last question, can you just permit me?
Yeah, please.
So, in your presentation, you mentioned about the AI and fulvestrate combination for metastatic ER-positive, HER2-negative breast cancer. Yes, it's a level 1 of evidence and in the NCCN guideline and recommendation. But my question is, if you use in the first-line setting this true drug, and after progression, you want to add the CDK4/6 inhibitor, then what will be your right endocrine partner for CDK4 and 6 inhibitor? Because you have already used these two pathway, and these two are the somehow the right partner for CDK4 and 6 combinations in all the trials.
For postmenopausal women?
Yeah, postmenopausal.
For postmenopausal women, this first option is the hormone, that is the second line hormones. If she got hormones in the adjuvant setting, then second line hormone should be tried, and then you can add fulvestrant. It works better if you add fulvestrant with hormones. It is already established, and if patient, despite of this treatment, if patient progress, then we should consider the endocrine resistant group, so that in these cases you can suggest the mTOR or like the cyclin 4/6 inhibitors. In this way, we should progress, I think so. And if patient in the meantime she present with visceral crisis or like some emergency, then you should switch over the systemic treatment. But if fulvestrant is added to the aromatase inhibitor, it is better than the single.
If you want to add CDK4 after that, then what will be your right endocrine partner for CDK4? Because you use both the pathway in the first line. So
Yes,
that time, what will be your partner?
Yes, if you add pembrolizumab in these cases, in cases you can add pembrolizumab with the other agents. You can there are some schedules with the pembrolizumab. You can go for this if patient progress after fulvestrant.
I think Lima wants to make some different comments.
Yes,
okay, Amal, do you have any opinion for this? Should we use the AI and fulvestrant in upfront? Because we have to use the CDK4 because now it's the magic drug.
No, pembrolizumab is very.
Yeah. So what is your opinion?
I mean, the sequence should be for me that yes, you can use AI or you can use the combination, both. So, I mean, the recommendation is if there is a history of previous AI, then you go with CDK4 together. Somebody in ESMO, they said parallel, you can use CDK4 first or you can use AI. And then if I start with, I don't start with.
I'm just telling it as a clinical practice. So if I have all the options, should I use this fulvestrant and AI as a first?
I don't use I use letrozole plus
AI and
AI and CDK4/6. Then I keep always. I want to keep the weapon for future. I don't.
I think
at the beginning.
Yeah, this combination is not very. Though it is a level 1 evidence, but I think this combination is not very.
But mostly our patients come with they already have been treated with the aromatase inhibitor in most settings. In the adjuvant settings, we already give the patients the aromatase inhibitor in case of postmenopausal women. So they have had this already. So whenever the metastasis occurred, then the next option should be chosen.
I think it's a CDK4 should be that time.
CDK4.
Yeah, it is okay. You don't need to change the hormone. Because on hormone, you add CDK4, you don't need to, as I was trying to mention, don't bring up fulvestrant at the front line.
This is my message. That was my message.
You keep it because at one stage it will fail. And then because at one stage, after second line, you cannot use CDK4.
Yeah.
There is no
CDK4. Yeah, this is that time. So I need to very helpless.
So, when you look at the study, always they start at the later stage, then bring in the front. And when they are very happy to prove in the front. But we need to think that what we have in our hand and how we are going to rationalize our practice and to get the best result out of it. Not because that was a session going on that how to choose the evidence for your own practice. That is very important. It is level 1 evidence, fulvestrant is possible.
Yeah, possible.
But you can keep it for future by using AI at the beginning. That is so. I think we stop it here, and now we are going to. I need a volunteer to the case discussion. Who will be the volunteer?
Sir, assalamu alaikum.
Yes.
Today, Sonia,
can I
will change?
Yes, Sonia. Yes, you can. So, Sonia, today our case is a 40-year-old lady came on June 9, 2019 with a recent diagnosis of breast cancer relapse. because she was a diagnosed case in 2017 when she was diagnosed T2N1M0, ductal invasive breast cancer, grade 3, ER/PR positive, HER2 negative. At that time, she was treated with breast conserving surgery, and pathology was, unfortunately, there was no neoadjuvant chemotherapy was given. I know Purit will jump in, but for any reason, it was not done. So, and then the pathology was tumor 23 millimeter, 4 lymph node positive, ER/PR positive, HER2 negative. Then she was given adjuvant 4-cycle AC followed by 4-cycle taxane and adjuvant radiotherapy. But in 2019, she has a left supraclavicular lump, and ultrasonogram was done, and FNAC confirmed is a lymph node metastasis. So the question is, will you repeat the biopsy for an receptor test, Sonia?
Yes, sir.
Yes, because we know there are big discordance between the receptors. So when there is a metastasis, we need to do it. Okay. So biopsy was done. It was found that it is again ER/PR positive, HER2 negative breast cancer. She had no other symptoms, and
Sir,
the tumors were normal.
There is some technical problem. I can't hear anything.
You can hear me? Can you hear me? Hello? Sonia, I cannot hear you. Hello? Sonia, are you
The
there?
PET CT is optional.
So can you
Sir,
hear
I can't hear anything.
Hello? Hello? সুমন, আমাকে কি শোনা যাচ্ছে?
I can hear
Yes, sir. Sir, you are audible, sir.
Sonia, can you hear me? আমি তোমার কথা শুনতে পাচ্ছি না। Sonia, are you there?
There is some technical problem. I can't hear anything.
You cannot hear me?
Sir, Sonia cannot hear you, sir.
So can we switch to somebody else?
Yes, sir. Maybe.
Who is it? Who will be the volunteer? Who will take care of replace Sonia? I'm sorry, we will miss Sonia. Anybody, quick.
So seeing the slide, the PET CT is optional, but I can't hear anything.
Okay, Sonia, we will allow you next day. So take a new volunteer. Devraj, are you there?
Ami sir. Yes, sir.
Who is it?
Hello. Devraj, sir. Devraj.
Okay, Devraj. So now my question is, will you do PET CT?
No, sir. It's not recommended.
No.
We will do the normal imaging.
What are the data says? There are few data, and all are retrospective data studies, and they have shown some benefit. But what NCCN is recommending that not to do upfront PET CT for metastatic breast cancer, rather to keep it to assess for treatment response. So now you look at the patient, that the patient is no more having a isolated nodes, but it is a de novo breast cancer metastatic patient with a liver metastasis. Now, shall we do surgery first?
No, sir.
No. Okay. And what should we offer for the bone metastasis? Now the patient has a... Hello?
Assalamu alaikum.
Sonia,
Yes.
next
week, Sonia, inshallah. So the patient have multiple vertebral mets and SOL in the liver. My first question was, will you offer her surgery? Next question is, what should we offer for bone metastasis?
We should not offer surgery, sir, and we should offer her zoledronic acid for bone metastasis.
Zoledronic acid. What will be the schedule, Devraj?
It may be 4 weekly, or it may be 3 monthly.
Which one? You have one option, either 3 months or 1 month.
Monthly, maybe.
Huh?
Monthly, sir.
So let's talk about the surgery. As Dr. Shahida was telling, if we look at the literature, there are some retrospective record review which was showing some benefit, but the prospective randomized control trial was the TMH paper that she was mentioning properly, and it was led by Professor Badawi, who is the director of TMH. and is a breast surgeon. And they have done a fair randomization, and they have shown that there is no survival benefit in doing the upfront surgery in metastatic breast cancer. And it was a paper of 370 patients. Equally, they have done a follow-up of 23 months. Median overall survival was insignificant between both the arm, and they have concluded no evidence to suggest that local regional treatment of primary tumor affects overall survival in patients with metastatic breast cancer at initial presentation who have responded to frontline chemotherapy, and this procedure should not be a part of routine practice. But the conflicting study is the Turkish study, as she said, that is MF0701. Again, this paper in 36 months didn't show any benefit, but on 40 months they have shown some benefit. But the criticism is that there was no chemotherapy before surgery, and the randomization was not properly done. Surgery arm had lower rate of triple negative breast cancer, 7 versus 17, and visceral metastasis was also not equally distributed. So this paper, even they gave a positive result, is criticized for this thing. But there is a meta-analysis of a huge number of patients and published 2020, and this meta-analysis has said that not to take a straight-cut answer, yes and no. Therapeutic option should be considered in selected patient after a careful multidisciplinary discussion. So this is the conclusion of this meta-analysis. So regarding bone, as you said, you will be using zoledronic acid. You are not sure about 4 or 12 weeks. And the question is there any superiority of denosumab on zoledronic acid, Debraj?
No, sir.
Sorry?
No, sir.
No superiority. Okay. So let's look at the zoledronic acid first. This is the Zoom study. They have shown that the comparison of 4 and 12 weekly, there is no difference. And not only one study, there are quite a few studies. They have shown that 4 weekly and 12 weekly zoledronic acid in metastatic breast cancer with bone metastasis have no difference. So now it is recommended that we should recommend rather 12 weekly than 4 weekly. And we can discuss about it, and data is in favor of using 12 weekly. Regarding the denosumab and zoledronic acid, this was a double-blind randomized trial, and they have not shown any overall survival benefit difference, but yes, on AE, there are some difference. So the difference is not on survival, but on SREs. So denosumab is maybe a better quality of life, but not a better survival. So NCCN is recommending both the thing together. So now let us come back to the case that she has this biopsy proven SOL multiple beta. We have given denosumab subcutaneously. And now question is, will you consider chemotherapy at the first time? Because she has SOL in the liver, there are multiple bone mets, but she is ERPR positive, HER2 negative. Debraj. Sorry?
Sorry, sir. I was unmuted, sir. I think I will consider chemotherapy as a first-line treatment.
It is a ERPR positive. There are SOL in the liver and multiple bone mets. You want to start chemotherapy first. Okay, let's see what our popular NCCN said. If there is no visceral crisis, then they say that both premenopausal and postmenopausal, we should try hormone first. And if it is premenopausal, they said hormone with overall ablation and systemic. This systemic is not chemotherapy. So there is in a different paper, the option is when even in ESMO, you say that first give ET, then endocrine therapy, response again endocrine therapy. If there is no response only, then switch to chemotherapy. So this is a meta-analysis published in Lancet, and there was around 50,000 patients. Hello? Hello? Yes.
We can hear you, sir.
50,000 patients, they have shown that chemotherapy, hormone therapy, first line or second line CDK4 hormone with CDK4 inhibitor plus hormone therapy are better than standard hormone therapies in terms of progression-free survival. Moreover, no chemotherapy regime with or without targeted therapy is significant better than CDK4 inhibitor plus hormone therapies in terms of PFS. And this our data support treatment guideline recommendation involving new combination of hormone therapies plus targeted therapies as first line or second line treatment in both setting in women of hormone receptor positive and HER2 negative metastatic breast cancer. So this is a huge paper published in Lancet, and they have shown that in 50,000 patient data that if it is a hormone receptor positive and HER2 negative, we should try with hormone and CDK4/6 inhibitor first.
Sorry, sir. I was thinking there was multiple as well in the liver. I should have thought about the liver function test.
Okay. So now you know that it is a hormone receptor positive. If you are using hormone endocrine therapy, what is the what hormone will you use, and what is the challenge of using a hormone therapy?
Premenopausal, we can use tamoxifen with ovarian ablation, and postmenopausal, we can use aromatase inhibitors.
You do ovarian ablation, and again you use premenopausal tamoxifen. Why you need ovarian ablation to give tamoxifen premenopausal?
Maybe there was a trial. I'm not sure, sir.
Okay. So if you do ovarian ablation, you have the opportunity to use AI. So the challenge was discussed by Peter Schmidt in 2016 ESMO, that there are some fast progress, and at the beginning there are some resistance. In Paloma trial and Falcon trial, we have shown. So these are the group who develop very fast resistance. This is the big challenge. But if we use hormone, the question is, will you use hormone alone, or if it is hormone alone, what one, AI, TAM, or fulvestrant? And if you use targeted combination, what is the expected benefit of making a combination of targeted drug, that is CDK4/6 inhibitor?
Sir, we can try endocrine therapy alone. May try.
If you want to combine,
if we want
the combination drug,
it may be a CDK4/6 inhibitor, sir.
What is the expected benefit, Debraj?
Benefit is, sir, progression-free survival will be longer, sir.
Okay. So ET alone or ET plus CDK4/6 inhibitor. The great Paloma trial published in NEGM, and they have shown that there is benefit in progression-free survival. It was the ITT group by investigator and by the central assessment. In both groups, they have seen that there's fair separation. And if you look at this forest plot, you see that all the benefit is in favor of combination. And if you look at the toxicity, that the majority toxicity, leukopenia and neutropenia. And if you look at the response rate, you see the fantastic response rate in the combination. So they have concluded that first-line palbociclib plus letrozole significantly improved median PFS that of letrozole plus placebo in postmenopausal women with ER-positive, HER2-negative advanced breast cancer. Median PFS was more than 10 months compared to placebo, and the p-value was significant. And palbociclib benefit observed in all pre-specified subgroups, and palbociclib was well tolerated with neutropenia and leukopenia, and this study supported the result of Paloma-1. And so if you look at the many other trials, you can see, as you mentioned, yes, in Mona Lisa trial, Mona Lisa 2 and Mona Lisa 7, and updated Mona Lisa 2 and Monarch, everywhere there is a consistent around plus minus 10-month PFS benefit by adding of CDK4/6 inhibitor. So that's why now it is a robust recommendation that for ER-positive, HER2-negative, stage 4 postmenopausal, we should use AI plus CDK4 inhibitor. And if it is premenopausal, again, we should use AI plus CDK4 inhibitor with ovarian ablation, not tamoxifen. So the patient, what about the OS benefit? Debraj, do you think there are some OS benefit in this patient, in this treatment?
No, sir. There is not significantly overall survival benefits, sir.
There are some OS benefit, Debraj. You can look at Mona Lisa 7 trial, and you can see that they have shown that there was some OS benefit. Not that much, but there was some OS benefit. Okay, so NCCN is telling that you go up to 3 times, and then if you fail, then you go to systematic therapy, that is the chemotherapy, or if there is any visceral crisis, then you go to this. So the NCCN, as I said, is recommending the combination. Now let us think about second line. First line failed after 10 months. So what do you think in second line? Is there any PFS benefit with second line, Debraj?
Yes, sir. There may be some benefits.
Yes. In second line, interestingly, still we are consistently 6.5 to 7.5 months PFS benefit we are seeing in Mona Lisa 3, Paloma 3, and Monarch 2 updated study. And also, you can see that some OS benefit also, even in second line. So this is a fantastic combination we are getting, that not only on first line, in second line, it is giving PFS and small amount of OS benefit. So is there any scope for maintenance CDK4/6 inhibitor after chemotherapy? Debraj, it is such a wonderful drug. Are you tempted to use as a maintenance?
Yes, sir. Yes, sir.
No. Unfortunately, there is no data to support the maintenance of CDK4 inhibitor. Maintenance should be done by only hormone. So in summary, we can say that it remains unclear if CDK4 inhibitor should be preferably administered first line or in second line setting. But if there is data to use it in first line, not to wait for second line. Majority prefer CDK4 inhibitor first line setting for the majority of their patient. No data supporting the use of combination of CDK4 and ET as maintenance therapy after chemotherapy. Maintenance therapy in this situation should be performed with hormone therapy alone. So, is there any other option? Say for any reason, the patient is not going to get endocrine therapy. Anything else you can think? Any other pathway?
Then we can go for the BRCA1/2 testing and see.
Any targeted therapy here?
ARP1 inhibitor, sir.
So we were actually trying to focus on this Bolero trial where mTOR is a
mTOR inhibitor
here. And we can, yes, you are correct. We can do BRCA1 and 2 and PARP also an option. But before that, we can think of this Bolero 2 trial and Bolero 4. But Bolero 4 is again criticized for a single arm study. And both of them have shown that everolimus plus AI is a valid option for some patients previously exposed to endocrine therapy, since it significantly prolongs PFS a bit without evidence of OS. The decision to treat must take into account the toxicity associated with this combination, lack of statistical significant OS benefit, cost, and availability. Tamoxifen or fulvestrant can also be combined with everolimus as per Leo trial. So if you look at the NCCN guideline, you see if it is a metastatic ER positive HER2 negative disease, it is preferred treatment option. If it is premenopausal, then ovarian ablation. If it is postmenopausal, no need. Straight. If it is primary, then on ET, if there is a metastasis, go for. If it is priority, you can use hormone plus AI plus CDK4/6 inhibitor or AI plus everolimus, or you can go for AI, tamoxifen, or fulvestrant. And if it is no prior endocrine therapy, again you can start with combination or a single drug. And again, the huge list of second line, almost the same like the first line. And if we extrapolate the data from other, with the visceral crisis patient or patient progressing very fast, then we cannot go for endocrine therapy. We can go for chemotherapy. Preferably, we should try with single agent. And if required, normally single agent is fair enough. Taxane or anthracycline could be the player. We can use capecitabine, eribulin, or vinorelbine. And if there is maximum response, then we can maintain again with endocrine therapy. So now again, look back to the case, this lady, now her ERPR is negative and HER2 is positive, Debraj. Just take a look here. So now, will you give chemotherapy? Debraj, are you
yes,
there?
Sir. Yes, sir. I will go for chemotherapy. Sir.
Single or combination?
I can go for, sir, combination with HER2. With HER2, single chemotherapy with HER2, sir.
Sorry?
Single chemotherapy with anti-HER2, sir.
Okay, very good. How long you will give the HER2?
So HER2 I will give for 2 years, 1 year, sir.
HER2 will give 1 year. Okay. So what about dual blockade?
Yes, sir. I can use dual blockade as per Cleopatra trial, pertuzumab plus trastuzumab plus docetaxel.
Okay. So will you start anti-HER2 early with CT or at a later stage when CT fades?
Of course, with early with CT, sir.
So will you continue the anti-HER2 therapy after the disease has progressed?
I can use anti-HER2 therapy with other agents, sir. Yes, I will continue anti-HER2 therapy.
Okay, so let us look into the data. This was the 2001 very old paper of New England Journal, where trastuzumab have shown a benefit over chemotherapy, and this was only 3 months, around 3 months benefit. That was the first paper, and there was a 20% reduction in the risk of death. And then the question of early use. This is a M77001 trial. Here there was two arm, the docetaxel and trastuzumab, another docetaxel 1 alone. But a group of patients, 53, crossed over from docetaxel to trastuzumab and docetaxel arm. And with this crossover effect, we can see that compared to 16.6 months, they have got a survival benefit for 30 months. So this crossover was showing that early use of trastuzumab is giving a survival benefit. So this is the trial which have given a data in favor of using early. And this is another study which was published in JCO in 2009. It is a German study. And they have shown the capecitabine and trastuzumab compared to capecitabine, and continuation of trastuzumab prolongs time to progression by nearly 3 months. If you're the median, you can see that it has, even after disease progression, there was a progression of survival by around 3 months. So that's why we tend to continue the trastuzumab even after the disease progression. So this is already we have covered. So regarding the first line treatment, this is a multicenter phase 3 trial, BCRG 007, and they have shown that trastuzumab and docetaxel compared with trastuzumab, carboplatin, and docetaxel. And they have shown that addition of carboplatin did not give any significant survival benefit. And this is another meta-analysis of 8 studies. 3 is single and 8 is combination. And in this meta-analysis, taxane showed as a single agent poorer than anthracycline, but when it was combined with trastuzumab, it has shown that it is giving a better survival. So this study concluded, this meta-analysis, that trastuzumab alone with docetaxel alone with trastuzumab is a good option for us. So regarding the drug of docetaxel, as it is quite toxic, this is a study called Harnata study, who has compared the use of vinorelbine. And they have shown that vinorelbine is non-inferior to taxane, but it is less toxic. So the vinorelbine could be an option with trastuzumab with equal outcome, but no less toxicity. Regarding the dual blockade, so this is the great Cleopatra trial, first interim analysis in 2012, and then they have finished in 2015, again near NEGM, where in interim analysis and also after 4 years, they have shown there was a benefit of first 6.1 month, then it is 15.7 month. But they have followed it up to around 8 years, and in Lancet, they have published their end of the study data, and they have shown that even after 8 years, this PFS of around median PFS of 12 months remained, and there was no additional cardiac toxicity. So this is the robust data of using dual blockade in metastatic along with taxane or any other chemotherapy drug. So now Debraj, what about any antibody drug conjugate that combines properly? Any antibody drug conjugate? Will you use TDM1?
Yes, sir. I can use.
When will you use it? Is it superior to trastuzumab and taxane? Is it?
It is. Yeah, it is superior. Maybe. It is superior.
Is it superior? Yes,
Yes
or no?
Sir. Yes. Sir.
Okay. So let's see. It is the phase 3 Marion trial, where they have shown that TDM1 non-inferior but not superior in efficacy, but it is better tolerated than taxane trastuzumab for first-time treatment of HER2 positive advanced breast cancer. So it is not superior. So what about the lapatinib?
We can use lapatinib as an anti-HER2 agent as a second line.
Okay, good. It is as in a MA31 study, lapatinib have shown PFS and OS benefit compared to in first line HER2 positive metastatic lapatinib combined with taxane associated with shorter PFS, more toxicity compared to trastuzumab and taxane. So lapatinib was the inferior outcome compared to trastuzumab in this MA31 study. And in cerebral study, lapatinib was compared with trastuzumab in combination with capecitabine. Again, also it was shown inferior. So there was a meta-analysis. There was a review article, systemic review on lapatinib, and they have concluded that we can use lapatinib because it shows some PFS and OS, not like trastuzumab, but as a second line. So if we can do a summarize, when pertuzumab is not given, first line regimen for HER2 positive metastatic breast cancer can include trastuzumab combined with a vinorelbine or taxane. Differences in toxicity between this regimen should be considered and discussed with the patient in making a final decision. Other chemotherapeutic agent can be administered with trastuzumab but are not as well studied and are not preferred. Lapatinib is inferior to trastuzumab. It can be used after progression to trastuzumab. So this is the summary that what we have discussed as for ESMO guideline. So now the patient, we have modified the situation. It is a triple positive, ER, PR positive, and HER2 new positive. So what will be your treatment, Debraj?
Is hormone therapy plus anti-HER2 agent, sir.
You will not use chemotherapy?
No, sir. Not in the first line, sir.
Okay, so as you said, for hormone and there are some options. Yes, we can use hormone plus anti-HER2, but it doesn't give any OS benefit. This is an interesting trial, a multi-center trial, but the one arm was added by Germany group. And this trial have shown that, that letrozole plus trastuzumab do better than letrozole. And letrozole, and this is more effective, letrozole do better in HER2 positive group compared to HER2 negative group. So again, it is another study, tandem, very small study, and they have shown that trastuzumab and anastrozole compared to anastrozole, and it have shown benefit. And the Partain trial, again, another trial, where also shown that we can combine endocrine therapy plus anti-HER2 therapy, and it can give some survival benefit. So this was the trial, alternative trial. They have compared all the three, lapatinib plus trastuzumab plus AI, and lapatinib plus AI. And all have shown benefit, and they have shown that lapatinib, trastuzumab, and AI was the best combination. So it is said that if in a group of patients in triple positive, when we don't want to give chemotherapy, lapatinib, trastuzumab, and AI could be a logical chemotherapy sparing alternative. But it should not be the first line. First line, we should think about chemo plus trastuzumab and pertuzumab. But if for any reason we don't want to avoid chemo, then we can think of this thing. So if we say that HER2 positive metastatic breast cancer, first line is chemotherapy plus trastuzumab and pertuzumab, or chemotherapy plus trastuzumab, or it can be in a selected patient, ET plus trastuzumab plus minus pertuzumab or lapatinib. In HER2-positive second line, beyond TDM1 or chemotherapy plus trastuzumab, or endocrine therapy plus trastuzumab. So this slide I have borrowed from Fatima Kartu, sorry for the name. So she have given a nice swimmer plot that on first line chemotherapy and then add trastuzumab, add some. Then when you use combined blockade, we are getting much more benefit with docetaxel 2015. On second line, again, capecitabine and lapatinib, and capecitabine, lapatinib, and TDA1 is, and third line, she mentioned that is physician choice. So by adding all these things, now in 2020, we have a good area where we're standing for metastatic breast cancer. But if the patient is TNBC, what drug will you prefer, Devraj?
I will prefer chemotherapy plus any targeted therapy. Sir.
Chemotherapy plus targeted. What target therapy?
Maybe CTK4/6, maybe if BRCA1 to
chemotherapy plus. It is a triple negative. Devraj, mind it. ER, PR, HER2, all negative.
Yes, sir.
So
we can.
It was offered single agent chemotherapy as it was not rapidly progressing one. Combination of gemcitabine and carboplatin or cisplatin 5-FU capecitabine may be given in visceral crisis or rapidly progressive disease. So patient is TNBC and BRCA test is positive. So will you give PARP inhibitor or carboplatin? So in TNT trial, it has shown that BRCA positive group do very good, around 34% response rate with platinum. And in Olympiad and EMBRACA study, they are in metastatic TNBC, the PARP inhibitor have shown benefit. So if you compare between these two PARP inhibitor, it is more of both are significant and it is comparable. But if you compare all the three, it is not head-to-head comparison, but we can think of choosing platinum because of the cost and the duration. So this ESMO guideline, which we read, was published in 2018, where we use it here. But today is 2020, and the patient started Taxane, was on TNBC patient, was on regular follow-up. After 4 months of Taxane, patient complained of abdominal pain. And again, we see multiple SOL in the liver. And what will you do? It is a TNBC patient progressed on chemotherapy in 2020, today.
We were using single agent chemotherapy, and now we can use combination chemotherapy. Now we can use even if it's a.
So will you use gemcitabine carboplatin, nab-paclitaxel, atezolizumab, biopsy?
So we can use
one and go for which one out of these 5?
So we can use biopsy to confirm again.
Number 1, 2, 3, 4, 5. Which option you want to take?
5, sir.
5. Good. Yes. Now, in 2018, we didn't have this paper, but now we have this publication that atezolizumab plus nab-paclitaxel make a good survival benefit. So that's why in this new review published in ESMO, they have added the third arm of metastatic TNBC, that if it is PD-L1 negative, then you go for clinical trial. But if it is PD-L1 positive, you go for nab-paclitaxel and atezolizumab. So last, I want to finish with a survival curve that was shown by a German group in a prospective PMK cohort. You look that if you look at the metastatic breast cancer patient, hormone receptor positive and HER2 negative, and HER2 positive group is doing almost near about similar survival today, and the triple negative is still lagging behind. So if we can treat adequately in an intelligent way, we can offer a very good survival even with metastatic breast cancer having many targets. So thank you, Debraj. Thank you very much.
Thank you, sir.
So now, Samir, are you there? Samir?
Yes, sir. I'm there, sir.
Can you put the quiz link in the chat box?
Sure, sir.
And go for the timer.
Sure, sir.
Please go to the chat box and look at the link. The link is already given. Samir, we want to see the timer. Do you have a timer, Samir?
Yes, sir.
Please.
Kamal bhai. Meanwhile, we can hear something from Dr. John during this quiz period.
Yes, John, you were, I mean, it was a very
waiting for him.
Silent day for you. So let me hear something from you by this time.
Yeah. Newer concepts.
Yeah, no, so apologies I missed the talk, but it sounds as though it was very comprehensive. In terms of some of the things that we discussed, oligometastatic disease is probably one of my most interesting clinical scenarios at the moment, and I think it's something which, as we all discussed, it's dependent on the patient, their histopathology, molecular studies, and really is on a case-by-case basis. So it really is important that they're discussed in a multidisciplinary setting. And if you're going to treat them aggressively, you really have to make sure that you treat all the areas of disease aggressively. There's no point doing radical surgery if you don't treat the bone metastasis, for instance, with ablative doses of radiotherapy. Yeah? So stereotactic RT. In the context of the National Health Service, we're actually limited at present. So patients with oligometastatic disease in the NHS, they aren't well served because we can't access radiotherapy, stereotactic radiotherapy for them outside of a clinical trial. And of course, therefore, they should be approached for clinical trials if you can recruit them. When it comes to molecular studies, so personally in my practice, I wait to the point where I'm running out of treatment options to see if they've developed any molecular targets. So again, in the UK, insurance companies are very reluctant to pay for molecular test, NGS tests. So if you're going to do it once, I tend to do it when we're beginning to extend beyond the standard lines of therapies that we normally use. And yeah, what's great in breast cancer is there's so many clinical studies. Peter was here a few weeks ago, and certainly in Barts Health, we're very fortunate to be able to offer patients access to some of the latest drug therapies in HER2, in immunotherapy, and in small molecule oral targeted drugs. So it's exciting times, for patients and oncologists. Thank you.
Okay. Thank you so much.
So John, there was a discussion between me and Shahida about PIC13. So what is your comment about this PIC13?
Upfront or after
so,
upfront?
Yeah, so I tend to do it when my patients have exhausted their routine treatment options, so their CDK4/6 and endocrine, and they're on chemo. I've got a lady now who is positive, but the problem is she's got cardiac toxicity from her anthracyclines sort of 10 years ago when she had early breast cancer. And the inhibitors aren't without their toxicities when they come to cardiac side effects. And I think, we're very au fait with the HER2 cardiac toxicities, but in fact, some of these new small molecules and even immunotherapies, they can have quite dramatic impacts on cardiac function. So it's really important to keep an eye on your patients when it comes to their cardiac function on these new drugs, because it can be devastating for patients.
What about ribocyclic and palbociclic? If you have both?
So I use Palbo. So I'm a big Palbo user personally. And in fact, one of the things I've So there's a study now, isn't there, looking at the continuation of CDK4/6 inhibitors once patients develop AI resistance on a CDK4/6 AI and switch to Faslodex. And in fact, I've got one lady who was very reluctant to have chemo. So she had a 2.5-year period of response to AI and CDK4/6. And she was very lucky. Her insurance company allowed us to switch to Faslodex and continue Palbo. And again, she's now on a 14 months of further response on treatment. So hopefully the trial will show that continuing the CDK4/6 backbone and switching AI may be a good rationale for those who develop, the certain kind of resistance mechanisms.
But again, in NCCI, it has been written that if in the first line of CDK4, the patient progressed, that there's no rationale of use this CDK4 combination in the second line setting. What is your comment?
Well, I think there may be a small group of patients where it does benefit them because they have the right molecular resistance mechanism, but I believe the trial is still in recruitment assessing that. So my lady,
in the second line, you also use the CDK4, the same drug, or you change
so normally
to ibimaciclib? Yeah, same drug.
So my one patient who continued, they just continued on palbociclib, but I have to say normally once they become resistant to CDK4/6 and endocrine therapy, I normally move them off then onto single agent drug therapy, either capecitabine or weekly Paxil or something. So that's my routine practice.
I think this is the most valuable recommendation for us. After first line, we can move to oral capecitabine rather than this NCP alpha-listic or something.
So one thing that we do a lot of is in oligo progression whilst on CDK4/6. So do you have much experience of treating sites of progression with stereotactic therapies and then continuing, or do you switch?
Okay, thanks, John. So now I need another volunteer for the rapid fire session. So
I want to.
volunteer?
Sir, I want to, sir, Riyadh.
Riyadh. Okay, Riyadh. So is 4-weekly denosumab superior to 12-weekly zoledronic acid in OS?
No, sir.
No. Okay. Is PET-CT a primary investigation metastatic breast cancer?
No.
Okay. So will you use chemotherapy as first-line treatment for hormone receptor positive and HER2-negative metastatic breast cancer?
No. No.
No, but
if there is no visceral crisis, yes.
So which trial proved the benefit of adding to trastuzumab, adding pertuzumab to trastuzumab in HER2-positive metastatic breast cancer, and what was the final follow-up period?
Cleopatra trial final follow-up period was 30 months.
Follow-up, median follow-up, not survival. I'm talking about follow-up, Riyadh.
Exactly, I can't.
We discussed it. It was the end of the study was around 8 years median follow-up, and the survival was 16.3 months. So in HER2-positive metastatic breast cancer, is there any benefit of adding second chemotherapy with taxane and trastuzumab?
No, sir.
No, because in BCRG 007 study, they shown the addition of carboplatin did not show any survival benefit. What was the conclusion of Harnata trial?
Sir, I forgot that.
Minoglobulin plus trastuzumab is plus trastuzumab with less toxicity. Why I mentioned it, because in our country we are always using taxane, but minoglobulin is not commonly used, but it is an option that we should keep in mind. So which trial proved the inferiority of lepatinib plus taxane against trastuzumab plus taxane in HER2-positive metastatic breast cancer?
Lepatinib plus taxane against MA31.
In first-line setting. Okay, what is the chemotherapy sparing alternative in triple-positive metastatic breast cancer patient not intended to get chemotherapy?
In which cases disease burden is small or low risk?
Aromatase inhibitor.
What is the
aromatase inhibitor? Aromatase inhibitor plus trastuzumab
plus
Lapatinib AI plus trastuzumab plus dapatinib.
Trastuzumab and AI, as per ordinative trial, shows 11 months PFS. What is the median PFS benefit observed with endocrine therapy and palbociclib in Paloma 2 trial?
Median, sir, I forgot that, sir.
More than 10.
24.8.
Which trial showed that TDM1 non-inferior to Taxane?
Emilia trial.
Better tolerability.
Emilia trial.
It's Mary.
It's median.
Okay. Fine. Thank you very much. So now we are almost at the end of our session. We want to tell you that today is the 10th session that we are running. And this total 10 session, our academic partner was Sanofi. We will be missing Sanofi from future because we will have a new academic partner, but hopefully Sanofi will come again. So today I want to request representative from Sanofi to give the vote of thanks. Lucky, are you there, or Nahid will be giving the vote of thanks? Nahid, are you there?
Thank you, sir. Yes, sir. I'm there, sir. Thank you, sir. Good afternoon, everyone. Our honorable chairperson, respected speaker, our respected moderator, and most important, our valuable invited guest. It's our privilege to have been asked for the vote of thanks on the special scientific event, academic sessions organized by Oncology Club. I'm Nahid Hassan, Assistant Manager, Sanofi Bangladesh Limited. On behalf of Sanofi and the entire team of Sanofi, I would like to show my gratitude for giving us the opportunity to this renowned academic scientific session organized by Oncology Club. At first, I would like to thank our today's speaker, Dr. Sadia Sharmin, for a very nice, informative presentation on the metastatic breast cancer management. And I would also like to thank our today's moderator, Dr. AFM Kamaluddin sir, for organizing this event and participating to the doctors in Q&A and sessions and interactive case discussions. I would also like to thank our today's special overseas guest faculties, Dr. M.D. Zakirullah, Dr. S.K. Farid Ahmed, and Dr. John Conibear, to participate in this event and giving the valuable inputs on the today's presentations. Finally, I would like to thank to my team member, Mr. Samid, for the backend support. Since this is the last event of participating Sanofi Bangladesh for the scientific partner, hopefully we will again be a scientific partner to the different upcoming events in these years. Until then, I think I would like to thank everyone for participating to this event and giving us the opportunity. Hopefully, we will overcome this COVID condition very soon and meet with you personally face to face. Until then, stay safe. Thank you very much, sir.
So, thank you, Nahid. Thank you to Sanofi for their wonderful support and to their team. And now, on the next week, there is a change that from next week, the program will be on Saturday and it will be from 7 o'clock. We will do from 7 to 7:30 to 9. And our next speaker will be uncommon histopathology of breast cancer. Speaker is, this Arman Reza Chaudhary, sorry for the typo. And another information is Oncology Club is going to have a 3-day virtual workshop on gynae-oncology from 4 to 6 September. And there will be plenty of faculties. And we have sent a link to everybody for registration. I request everybody to register themselves. Our president, Professor Hai, was not available at the beginning. Now I have seen Sir joined us. Now I will say Sir to say a few words, then I will declare the prize winner. Sir.
Thank you, Kamal. I'm sorry I couldn't join earlier. I missed the lecture of Dr. Sadia. It's my bad luck. But I have been able to watch and see the discussion. One thing I want to say to you, you people have made the breast cancer management very, very difficult and confusing. I remember my old days when I started my career in 1969 and 70. In those days, we used to get cases, breast cases as referred from the surgeons. We note a case of breast carcinoma, breast mastectomy done, advanced radiotherapy referred to the department. This is the note we could get. No histopathology, no nodal status, no, no staging, nothing of this. We used to treat that with my 250 kV machine. In that case, the surgeon was happy, patient was happy, I was also happy. All happy, happy situation. Now people have become this, make this thing very, very difficult. Thank you all very much. Continue on this. And Kamal, you said that from next week we'll have our virtual meeting on Saturdays at 7:30 to 9 a.m. or p.m.
PM, sir.
Yes.
So,
okay. Thank you all very much. Bye.
Thank you, sir. As sir said, things has changed and option has increased. Good for patient, maybe good for doctors, but difficult for doctors. So life become difficult. And as sir missed today, we send the link to everybody, the video link and all the presentation. May I request our junior colleagues that please go to the, yes, Zakir Bhai, I'm coming. Please go to the video link to listen to the presentation if you miss something, and go to all the papers. Try to go through every single papers, because we don't discuss everything in this 1.5 hour time. But we request that you should pull out all the papers. If you need any full paper, you can contact to our email. We can provide you the full paper. The objective of this program is so that you develop the habit of reading the paper, understanding the message that was given, the strength and weakness of the study. We are trying to educate ourselves. We are trying to improve ourselves. So this is the small tips that for the juniors, please go in the evening or off time, go to the recording, see the video, see the presentation, try to take out all the papers. If you don't get it from Hinari, contact us. We will try to provide the full paper. Yes, Zakir Bhai, you had some comments.
Right, just only one thing. I mean, Professor Peter Schmidt called me and said thank you to all the Oncology Club Society members, because he received his gift from generous gift. He said there was no need of that, but of course he said he sent his gratitude and thank you, and he's very keen to come and join in Oncology Club meeting in future personally in Bangladesh. And John has already conveyed his thanks to you as well directly for receiving that gift as well. So it's a fantastic gesture from Oncology Club. Thank you.
Thank you, Zakir Bhai. Just for everybody's information, one day John was trying to celebrate his birthday alone, so we didn't allow him to be alone. So we wanted to be party, and we took the help of Zakir Bhai and sent our gratitude to him. So that was the acknowledgement, and at the same time, we wanted to acknowledge the participation of John Peter Smith, and we are so happy for their response. We are overwhelmed with their warm response, and we will be eagerly waiting to meet them virtually and physically. We are having a plan to have a virtual program in October, and there we will be expecting John and Peter both. And definitely physically, we want to see the John is a known face now. We want to make Peter as a known face. So now we are almost at the end of the session. It is next, we will have a new partner from next week, and the timing will be at the evening. Please don't log in the evening, afternoon time. On Sunday, it is on Saturday evening at 7:30. And now let me declare, and this is the gynecology session that I mentioned. Please try to participate. And now the winner. The winner is, again, Riyadh. He has scored 100 out of 100, and he is the winner today. Riyadh, congratulations.
Thank you, Riyadh. Thank you, sir.
So now I want to finish. Thanks to our today's speaker, Sadia. I'm proud of you that, as I mentioned at the beginning, that you are one of the most brilliant students that I have seen when I was...
Sir, please, sir, just for 1 minute. Riyadh is now corona positive. So everyone pray for him.
Inshallah, he will be.
Surely, inshallah. Okay.
Inshallah, he will be. So Sadia, I'm proud of you. You made a wonderful presentation. Thanks to all the participants for such an active, interactive discussion. And I see some of our senior colleagues like Kamruzaman Bhai is there. Your participation, your presence always gives us encouragement. Thanks for joining. And
thank you, Bhaiya.
I am thankful to Aisha. She is always making us feeling great that our program is no more regional, national, it becomes international. Thanks, Aisha, for keeping confidence on us and participating and enriching us with your inputs. And to all our participants, discussant who made the session lively. Our objective is not only one-way discussion. Our objective is to discuss among us. We should discuss on the basis of evidence, and we should learn how to practice evidence-based medicine. Again, as Haisar said, now we have so many things in front of us. Shahida was trying to push something by pushing me and John, that when you have so many food in front of you in the buffet, you need to be very intelligent which one to choose and how to use it. Multiple option is sometimes suicidal. So in breast cancer, now we have so many options, but we need to use it very intelligently, very wisely, so that we can use judiciously and give the best benefit out of it. We should think about the drug toxicity. We should think about the financial toxicity. We should think about the weakness of the study, which recommended the drug. So with all these few words, I want to finish today. May Allah bless us all. Let us all stay safe. Till next week, Saturday. We meet you again on next Saturday at 7:30 p.m. to listen to more discussion about unusual breast cancer. And there we will be discussing about the radiotherapy portion. That will be the practical part. We will be trying to show some practical issues on a very recent paper published on different type of nodal radiation. So they have make a very nice publication on that. We will be trying to make different fields and how it works to make more clear about the nodal radiation. So thank you very much. Thanks you all again for your wonderful participation. And last but not the least, I personally acknowledge the support of Sanofi for last 10 programs. Thanks, Sanofi. Looking forward to meet you again as getting you again as academic partner in future. Thank you very much.
Thank you.
Okay, bye-bye, everybody.
Thank you.
Bye-bye.